Okay, a very good morning to everyone. I see that the weather outside is actually quite beautiful, but thank you all for staying indoors to join us for this. Uh, Taylor Swift is in town, right? But I don't think most of us are going there, or we are not going now, lah. So at least for those who are going to enjoy Taylor Swift, join us now for some more education first prior to that. It's a beautiful Saturday morning. I'd like to thank you all for taking time out from your own busy lives to join us in our Clean Movement webinar session 2 for 2024. Today, the focus of our topics will be about bowel dysfunction and clean and practical strategies to move and control your bowels. We have a very good program today with three fantastic speakers. Dr. Surendra Mantoo, a senior consultant, general and colorectal surgeon from Khoo Teck Puat Hospital. Ms. Megan Ho, a senior dietitian from Khoo Teck Puat Hospital, and Ms. Yip Wan Hui, very experienced pelvic floor physiotherapist who works at City Health Physiotherapy. We will start with the three speakers, and then we will follow on with the Q&A at the end. Now, this whole webinar is organized by the Society for Continence of Singapore. I'm Dr. Lim Jit Fong, and I'm the president of the Society for Continence Singapore. We are a charity that is focused on improving the knowledge and care of all sufferers of incontinence in Singapore. And today's webinar is part of our vision to raise the awareness of what continence management and pelvic floor care will be for Singapore. So I'm going to let Dr. Surendra Mantoo start now with the first talk, and his topic will be what is bowel dysfunction and how do we manage it? Dr. Surendra?
Good morning, everyone, and thank you for joining us on a Saturday morning. My name is Dr. Surendra Mantoo, and I am a colorectal surgeon. And today I'll be talking about what is bowel control problem, which is commonly known as fecal incontinence, how to manage it, and what are some of the common myths associated with fecal incontinence. So I will be playing the role of a myth buster today, and stay with me. I will be telling you what are the myths and what are the facts related to fecal incontinence. Now, I work in Khoo Teck Puat Hospital. Some of you might have been there. It's a very green and beautiful hospital. And this is going to be the outline of my talk. I'll talk about what is fecal or bowel incontinence, what are some of the common causes, what are some of the common myths, and what are the facts related to it, how can we control and manage fecal incontinence, and at the end, there will be a take-home message. Now, fecal incontinence has multiple interpretations, some associated with diarrhea, some lack of hygiene, some bathroom problems. But by right, any involuntary passage of gas, liquid, and or solid stools should be considered to be fecal incontinence. And it should not be related to that you have diarrhea, you have loose stools, or you have hygiene issues. If you are having no or minimal control over the passage of gas, liquid, and or solid stools, you may be suffering from fecal incontinence. Now, there are multiple causes for fecal incontinence. If you want to understand the causes, we need to look at this diagram, which shows the picture of a colon or the large intestine. And the causes of fecal incontinence are mainly related to the last part of the colon, which is the rectum and the anal canal and the structures which make it. Now you can see there are some muscles around the anus and the lower rectum. We call it internal and external sphincters, and there are some nerves which supply it. So any problem with these sphincters or the nerves or with the function of the rectum or the anal canal can cause fecal incontinence. Now, in terms of what is the commonest cause of fecal incontinence, is the childbirth. Now you can see in this picture, this is the picture of a vagina, and very close behind it lies the anus in the female anatomy. Now, during childbirth, there may be some difficulty in for the baby to come out, and many a times the surgeon may make a cut. As you can see, this red dotted line, the surgeon may make a cut to allow the baby to pass, but sometimes this cut can extend close to the anus. We call it in medical terms episiotomy, and this episiotomy sometimes can damage the sphincters around the anus, and in future can lead to fecal incontinence. Now, many females are young at childbirth, so they may not feel the effects of the episiotomy or the cut at that time. But as we age, our muscles become weaker. There are some hormonal changes and some other factors may contribute. And that's why towards like mid 50s or early 60s, most patients will have the consequences of this episiotomy as fecal incontinence. There are some other common causes of fecal incontinence, like commonly a bile surgery, if not done properly, anal fistula surgery, or for that matter, any surgery done around the anus, which can damage the sphincters, can lead to fecal incontinence. There are some contributing factors like long-term diabetes, renal failure patients, immobile patients, or even aging can also contribute to the fecal incontinence in a person. Now, how would you recognize a typical patient with fecal incontinence? There are some telltale signs. Usually they are middle-aged. Fecal incontinence is more common in females who have a history of vaginal delivery, and they may also have a prolonged or difficult labor. Sometimes the use of forceps or even an episiotomy has been done to help the baby to come out. And they typically are depressed, shy, lack confidence, and there are reasons for that, which I'll be sharing with you all in my further slides. Now, some of the common myths which are associated with fecal incontinence are discussed here, and I will discuss them one by one and tell you what are the facts. It's a very common myth that fecal leakage of feces is not common. We also, many patients tell me that I'm not incontinent, but I just have diarrhea or loose stools, which is again a myth. Incontinence is also associated with aging, and it is considered to be a part of normal part of aging, which is again not a truth. And many people believe that it is a minor inconvenience. It does not actually affect the quality of life. And many people, as well as patients, as well as even physicians like doctors, believe that there is no treatment for fecal incontinence. Now, I'll start with the first myth, that leakage of feces is not common. Now, leakage of feces suffers from this typical iceberg problem. Many of you might have seen an iceberg, which is seen above the level of the water and may look very small, but the underlying problem is huge, and that is the reality. Now, if we talk in terms of numbers, on an average, it has been seen that 2 to 5% of general population suffer from fecal incontinence. But as we age, about 10% of general population above the age of 65 years old may suffer from fecal incontinence. And when we talk about certain facilities like nursing homes, nearly half of these people suffer from fecal incontinence. But unfortunately, we do have little information about the incidence or the prevalence of fecal incontinence in Asia and in Singapore as well. So most studies have underreported the problem, and as a result, many patients suffer in silence. Now, if you talk about Singapore, we can say that if conservatively, if 5% of our 5 million population suffer from fecal incontinence, we can easily have a huge number of 250,000 or 250,000 people who are suffering from fecal incontinence and are actually not going to seek help from the healthcare facilities. Now, some of you might have also recently read in the newspapers or heard in the news that Singapore in 2 years' time will be a super age society, which means more than 20% of our population will be more than 65 years old. So that means we'll be seeing more and more patients with bowel control problems, fecal incontinence, and the consequences of it. In the same newspaper, I read an article which touched me that even if we age, Singapore does not have to be a sad society. And one of the reasons for this being a sad society is when we suffer in silence, and fecal incontinence could be contributing to that. Now, the question is why patients don't come to seek help. And that is because there are multiple challenges associated with problems like fecal incontinence. There is kind of social stigma. Patients are embarrassed to talk about it. And there is a general lack of awareness, not only among the patients, but among the healthcare professionals as well, about managing this issue. And most patients live with incontinence because the common belief is that there is no treatment. The second myth, which I said, I face also many of my patients when they come to the clinic, and when we talk about incontinence, they will say they have just diarrhea. It's not incontinence. And in fact, there is a saying that fecal incontinence gets lost in translation. Patients may call it lack of hygiene, issues with diarrhea, issues with colon. But in reality, patients don't tell and physicians don't ask. In fact, one of the studies showed that more than 70% of incontinent patients did not voluntarily report fecal incontinence. That means if they were not asked, they wouldn't talk about it. And similarly, when physicians asked about fecal incontinence, more than 75% of patients reported that they did have some problem with control of feces. So this peculiar problem with a disorder like fecal incontinence has led to heavy underreporting of the problem. So we actually do not know how much or how many patients are actually suffering from this problem. So this is a challenge, and we need to break the barrier so that patients find the right words and physicians ask the right thing from these patients, and so that we can help them. Now, how to overcome this issue? I call it look towards east, which is we need to improve education about. I'm so happy that all of you have joined us today so that we can, learn from each other and educate about this common but underreported disorder. We need to improve the awareness, not only among the patients, but as I said, even many doctors or nurses at the polyclinic level, at the GP level, or even at the hospital level are unaware about the options of treating or managing this problem. We need to support these patients so that they are not embarrassed to talk about it. And more importantly, we need to train more healthcare professionals, including nurses, physiotherapists, pharmacists, dietitians, as well as the doctors, so that we can manage these patients very effectively. Now, the myth third is that many people consider that incontinence is a normal part of aging. But the fact is that incontinence is normal only in very young infants. And in people of any other ages, it should be considered abnormal. We know that it may be common in old age, but fecal incontinence is also common in other younger patients. And there are multiple other causes like post-childbirth, which I discussed, menopausal women, post-hysterectomy, after any anal and rectal surgery. That means even males or females at any age can suffer from fecal incontinence. The myth four, which is actually very important and not discussed many a times, is that incontinence is a minor inconvenience and does not affect the quality of life. But the reality is when a patient suffers from fecal incontinence, their whole life revolves around it. They cannot enjoy simple pleasures like going to watch a movie because they're worried about the smell around them. They cannot go for simple exercise or even for the pleasure of swimming because they are worried about leakage and what other people will think about them. And they usually are confined to the homes because travel is a big undertaking for them. When they want to travel, they always think about toilets around them because they are very worried that if they go for a long drive or a flight or Even any other outing, they're more worried about the toilets, finding the toilets at the right time, and more worried about the leakage rather than enjoying some simple pleasures of life. So in reality, there are a lot of negative impacts of fecal incontinence of life. Many of these patients suffer from poor image. They isolate themselves. They are anxious and depressed. It also affects the sexual life. Imagine a patient is worried about leakage of feces, uh, then sexual fulfillment becomes a secondary enjoyment for these people. And many patients also, there's a loss of financial freedom because it's not easy for them to go out and work full time. They're more worried about their leakage, the smell around them, and what people will think about them. So in fact, there is a saying that fecal incontinence may not kill, but it takes the life out of a person. So it's a very not only physically difficult problem, but it's also mentally and socially as well as financially a challenging problem for these patients to manage. Uh, One of the common myths among the healthcare professionals, including doctors, is that fecal incontinence cannot be treated. But in reality, fecal incontinence can be treated in majority and controlled in almost all. We treat it like any other medical disorder. It's no different than any other medical disorder. But the challenge with treating or managing fecal incontinence is the identification. So unless the patients come forward to seek help, it is very difficult for us to manage them. So we need to increase the awareness among the public, among the patients, among the other healthcare professionals, so that they can identify these patients and encourage them to seek the right kind of help with the right kind of healthcare professionals. Just like any other medical problem, we start the treatment with assessment of severity, because fecal incontinence can be a minor issue in certain patients, but it can be a very serious or major issue in certain patients. After assessment of severity, which can be done at the community level, if we know the right kind of help, we can refer these patients to appropriate specialists, which investigate. I will show you some of the investigations we do to look at the severity and then decide about the treatment options. A majority of these patients will be treated with medical management, and certain select patients can be offered surgery, which can lead to improvement in their function as well as quality of life. And we do follow up these patients because besides the medical issue, they do tend to have other issues which should be managed and taken care of. Now, if we talk about assessment of severity, it's a very simple thing. At a personal level, a person can maintain a bowel diary, where you just have to indicate the number of bowel motions, the number of leakages, was it gas, liquid, and it helps us to know how bad or severe is the problem. And when you come to a healthcare facility, we use some standardized scoring, which are again very simple. Like one commonly used one is here, Wexner score. Basically, we report what is the, how common is the incontinence in terms of solids, liquids, gas. Does the person have to wear a pad? Or is the lifestyle altered? And depending upon the score, we can categorize it into mild, moderate, and severe. And depending on the severity, we treat the patient accordingly. So it's a very simple thing, but many people don't understand about it. Now, when we come discuss about investigations. Now, again, investigations are very simple. And usually two investigations are done for this patient to assess the severity and whether they can benefit from any surgical intervention or not. The first one is anorectal manometry. Now, it simply checks the pressure of or the strength of our backside or the anus. With this simple instrument, as you can see in the picture, which is inserted in the anus, we can check the sphincter length, We can check the sphincter pressures, what is the resting or the normal pressure, and what is the pressure when the patients try to control or hold the motion. We call it squeeze pressures. And we also can check about the rectal function, whether the rectum, which is usually related to storage of the feces, whether it is normal in capacity or not. And then we get a simple graph like this, and we can know what is the pressure function of the anus in terms of the pressure. Is it low? Is it normal? Or is there any other abnormality? And then we can also know, as I said, that sphincters around the anus are very important in maintaining the continence. With a simple ultrasound in the anus, is just like doing a finger check. We can know the anatomy, or rather the structure of these muscles. As you can see in this picture, because of the episiotomy in this person, you can see normally we must have two rings around the anus, but this ring is broken as shown by the red arrows in this ultrasound picture. So it's a very simple, non-invasive, painless procedure which can tell us about the anatomy or the structure of the muscle. And many of these patients actually can go for surgery and they can have a better quality of life. Now, when we talk about medical therapy, most of the times we start with simple medications like antidiarrheal medications, which reduce the stool frequency. And in fact, it has been shown to improve the quality of life, because I tell these patients to take 1 or 2 tablets when they want to go out, and then they can stay dry for the next 6 to 8 hours. But the problem is that it is effective in only minor incontinence. So in moderate to severe incontinence, these medications may not be very useful. We also try to increase the bulk of the stools by giving some fiber, and this can be titrated in individual patients, and looking at the response and how the symptoms are improving or not. Now, one of the important management options for managing bowel control problems or the fecal incontinence is called biofeedback. Now, it's a technical term, but in simple, it means we want to exercise the pelvic muscles of the patient. It is done by a trained physiotherapist and is tailored to an individual patient. So it's just like when we want to improve the strength of our arm or leg, we do muscles, we do squats and other exercises. Similarly, we need to have specific exercise plan for these pelvic floor muscles. These are commonly called Kegel exercises, but they have to be practiced over a long period of time. It's just like, we cannot make our muscles or, six-pack abdomen over a short period of time. It takes months and sometimes years. It's similarly that when we want to exercise our pelvic floor muscles, we need to be consistent and practice over a long period of time. And they do show improvement in certain patients. Now, when we come to discuss about the surgical management, how we can give some relief to these patients by offering them surgery. Just for you to understand, I have categorized them into 5 groups. I call them 5 R's for your simple understanding. First R is repair. We can repair, as I shown you earlier in the ultrasound picture. If the muscle is damaged and it is easily repairable by the surgery, we can do a sphincter repair. And it has shown good results in the short for 4 to 5 years after the surgery. Many patients have become almost perfectly continent. If there is problem with the nerves, we have some ways to re-innervate the nerves. We call it sacral nerve stimulation or posterior tibial nerve stimulation. Posterior tibial nerve stimulation is a very simple, minimally invasive procedure, can be done on an outpatient setting, and many patients do get benefit out of it. Sometimes we can reinforce the muscles with the help of magnetic sphincters, or there are some bulking agents which we inject around the anus to make it more stronger. And finally, if nothing works, then we can make a stoma, which actually improves. Stoma means we put a bag on the abdomen so that the feces are diverted into the bag. And many a times it has shown that it improves the quality of life of a person, because now you have a controlled passage of feces into the bag rather than uncontrolled feces around the anus, which is very difficult to clean and causes more problems than any good to a person. Having discussed the management, it's important to talk that we go with a stepwise approach. It's not that the patient comes to us, we offer surgery upfront. We basically assess them, and we always start with the first line treatment. That's why we have our dietitians who are involved in the care of patients. We have our physiotherapists involved in the second line of treatment. So it is not the work of one person or a one individual. It is a teamwork. There are multiple people involved in taking care of people who suffer from fecal incontinence. So from first line to fourth line, you can see there are multiple peoples involved in taking care of these patients. Now, these are some of the important people who are involved in taking care of patients who suffer from bowel problems, right from the nurses, physiotherapists, colorectal surgeons, general physicians, dietitians, and even these patients may need some psychological support in terms of a psychologist or a psychiatrist, because as I said, it not only disturbs your function, but it also disturbs your mental well-being. So in short, there is a teamwork. Multiple people are involved in taking care, and we must emphasize that these patients are not alone. There are many people who are dedicated in treating, and there are many organizations like Society for Continence. We are a like-minded people who want who are involved in this society, and we have a genuine desire to help these patients, so that they know that they are not alone, and they don't need to suffer in silence. There is help available outside, and they can be treated as well. Now, coming to the take-home message, as I said, I will be playing the role of a myth buster today. So the common myths are on the left-hand side and the facts are on the right-hand side. So the myth is fecal incontinence is a normal part of aging, but by now you must know that it is abnormal at any age other than infancy. Fecal incontinence is not a medical issue, but the fact you must realize it is a medical disorder and can be treated like any other medical condition. I'm not just incontinent, I just have diarrhea, but in the reality, any involuntary loss is and should be labeled as fecal incontinence. Many people believe that nothing can be done about it, but as I said and discussed and showed you some examples, that control and cure are possible. It is just a minor inconvenience. We all need to think again. It's not only a medical issue or a medical inconvenience. There is a lot. It affects the mental well-being, social well-being, as well as the financial well-being of a sufferer. So we all need to play a part, and hopefully we can help these patients so that they can enjoy and fulfill their lives. Thank you very much for a patient listening. I'll be happy to answer any questions at the end. And I will hand over to the next speaker. And